Hello everybody. Please let me know if I'm audible and visible and you are able to see the presentation, and then we'll start. I hope I'm audible and visible. Okay, so today's short session that we will be having, this is an MCQ revision session on ophthalmology investigations. So ophthalmology investigations are something which have become largely very important given the recent trend of questions that we are having, where we are getting more of clinical and case scenario based questions. So we are getting lot of questions on investigations in ophthalmology, and ophthalmic investigations, that is what I chose for this session of MCQs for NEET PG, right? So I will put up the question and then let us go ahead and discuss everything that is related to that particular question. So I'll come to the first question. See, what is the diagnosis from this photograph? So the options that are given to us are, see, this is the photograph that is given to us, and the options given to us are, is this a normal cornea? Does this give us a diagnosis of keratoconus? Does it give us a diagnosis of macular dystrophy, or does it give us a diagnosis of Fuchs dystrophy? So what will be the answer to this question? Is this a normal cornea? Is this keratoconus? Is it macular dystrophy, or is it Fuchs endothelial dystrophy? Right, so this is the answer to this question is, this is a picture of Fuchs endothelial dystrophy. So first of all, let us try and understand what is this investigation and what is this image that we are looking at. What is this investigation and what is this image that we are looking at? This investigation that we do, this is called as specular microscopy. So what is this? This is called as a specular microscopy. Now, where do we use specular microscopy, or what is it used to evaluate? Now, specular microscopy, this is an investigation that is used for evaluation of the corneal endothelium. So this is an investigation for evaluation of the corneal endothelium. Right, this is an investigation for the evaluation of the corneal endothelium. So let us look at these endothelial cells here. What are these cells? See, these cells, if you look at these cells, see, they are hexagonal in shape. These cells, they are hexagonal in shape. So, and they are tightly packed. So these cells are hexagonal in shape and they are tightly packed. So this is what a normal corneal endothelium looks like. Now, if you look at the picture that has been given to us in the question, so what is the picture that has been given to us in the question? The picture that has been given to us in this question, here if you see these large black areas. So what are these large black areas? These large black areas, these are the endothelial cell dropout areas. So what are they called? They are called as the endothelial cell dropout areas. So in these endothelial cell dropout areas, these black areas, they are also called as the gut tape. And here the endothelial cells are absent, and therefore to fill up these gaps, the surrounding cells that you have, these surrounding cells, they are changing their shape and their size. So these cells, they show what is called as pleomorphism, meaning they change their shape, and they also show polymegathism. So pleomorphism and polymegathism. Okay, so this pleomorphism and polymegathism, this is suggestive, with these endothelial cell dropout areas, this is suggestive of Fuchs endothelial dystrophy. So what is this? This is called as Fuchs endothelial dystrophy. So let me just go over this picture once again. Why this is called as Fuchs endothelial dystrophy? So what is this? This is basically a picture of the corneal endothelium. So I showed you the picture of the normal endothelium, where you have these tightly packed hexagonal cells. And then the picture that was given to us in the question, where you see these large black areas, which are the endothelial cell dropout areas, where the cells are absent. And because the endothelial cells are absent, that is why the surrounding cells are trying to fill up that fill up that space by increasing their size, that is polymegathism, or changing their shape, that is pleomorphism. So this is a picture of the corneal endothelium, which is telling us about Fuchs endothelial dystrophy. So this, I feel, is one very kind of a very diagnostic image which can possibly come in the exam. Given the recent nature of questions where we are having more clinical questions, more case scenario based questions, I think this is a good possibility. Okay, now let me go to the next question. What is the diagnosis from this photograph? So this is an investigation that's been given to us, and now we are asked what is the diagnosis from this photograph. Is it a normal cornea? Is it a macular dystrophy? Is it a Fuchs endothelial dystrophy, or is it keratoconus? So what can we call this now? Any idea what we should call this? Is this a normal cornea? Is this a macular dystrophy? Is it a Fuchs endothelial dystrophy, or is it a keratoconus? Okay, let me tell you, this is a keratoconus. Now, why do we call this as keratoconus? So, first of all, what is this investigation? This investigation, this is a corneal topography. This investigation, this is called as a corneal topography. So, first, let me show you what a normal corneal topography looks like. So see, these are two pictures. This is the one that we had in the question. I will name this as 2. And the first one, this is a normal corneal topography, or this is the topography of a normal cornea. Now, first of all, see, when you look at the picture, that is picture number 1, what you see there is, see, the whole color coding is in green. Now whenever we have something which is color coded in green, the general impression that we think that it is normal, and that's how it is here also. It is normal. Now why are we calling this as normal? Because see, if you look at the values that are there here, look at the values that are written here. The values generally range between say 40 to 46. Now, we know that the average dioptric power of the cornea is around 44 diopters. So, on an average, the dioptric power of the cornea is around 44 diopters, ranges between something like 40 to 46. So, if the cornea has a normal dioptric power, then that means that it has a normal curvature. So, this picture shows us that the dioptric power throughout the cornea is normal, which means that the curvature is also normal throughout the cornea. Okay, so the dioptric power is normal, which means that the curvature is also normal. Now look at picture number 2. Now if you look at picture number 2, what you will get to see is that in this particular area, look at this particular zone. It is coded in red, and whenever we see something in red, we generally think it's abnormal. So it is that zone, that area which is shown in red, that's abnormal. Now why that is abnormal? Because see, if you look at the values that have been given here, the values are in the range of 64, 65, etc. So what does this mean? It means that that localized zone of the cornea has high dioptric power, suggestive of high curvature. So that small area has got high curvature and high dioptric power. So this is a topography of keratoconus. But ideally, along with this curvature, we should also be able to establish that the thickness at that particular point is also decreased. Because keratoconus by definition means that there should be increased curvature and there should also be decreased thickness. So increase in curvature along with decreased thickness, that is what gives us a diagnosis of keratoconus. So in this you can see that this particular zone, this is only a curvature map. So that's why we are showing that there is a localized area of increased curvature, and that is why we are saying that this is keratoconus. So this is another very typical and suggestive investigation. This is a corneal topography which shows us keratoconus. Okay, so I have shown you two questions on investigation. The first was a picture of a specular microscopy where we saw the picture of a Fuchs endothelial dystrophy, and the second one is the picture of a corneal topography which shows us the picture of keratoconus. Okay, now let me show you another investigation. Identify this investigative modality. What is this? Is it a USG B-scan? Is it a USG A-scan? Is it an anterior segment optical coherence tomography? That is it AS-OCT or is it FFA, fundus fluorescein angiography? So will any one of you be able to answer this question for me? What is this investigative modality? What is this investigative modality? Will anyone be able to answer this question? Okay, let me tell you, this is AS-OCT, anterior segment optical coherence tomography. This is an AS-OCT. So this is basically a scan of the anterior segment of the eye. So let me just help you to identify the structure. See, this is the cornea, this is the iris, this is the crystalline lens. Now this is the anterior chamber. This is obviously the anterior chamber, and this is the angle of the anterior chamber. This is the angle of the anterior chamber. Okay. So this AS-OCT, this is used to study. It is an imaging technique which is used to study the structures in the anterior segment. So see, we have the cornea, we have the iris, the anterior chamber, the lens, and we can also study the angle of the anterior chamber, which is of particular importance. Where is the angle of anterior chamber important? Obviously, it is important in glaucoma. So I'll show you one of the very important uses of AS-OCT. So see, let's name these two pictures as picture 1 and picture 2. Now see here, look at the angle here. If I have to study the angle of the anterior chamber, then look at the angle in picture number 1 and picture number 2. So basically, this investigative modality is of extreme importance in glaucoma, where you see here in the first picture, you see how wide open the angle is. So this is an open angle. And here you see the angle is very narrow because the space between the iris and the cornea is very minimal. So this is a narrow angle. So all of you know that glaucoma is classified as OAG, that is open angle glaucoma, or ACG, that is angle closure glaucoma. So this is one investigative modality which helps us to confirm this diagnosis of OAG or ACG. So it of course helps us to study the other structures in the anterior segment like cornea, lens, iris, anterior chamber, etc. But it has a special use in classifying glaucoma as OAG and ACG. So that is the importance of this investigative modality. Okay? Chalo. Let me show you another question on ophthalmic investigation. This field defect, the field defect in this photograph. So see, this is a perimetry picture, right? This is a picture of perimetry, and we are being asked what is the field defect in this photograph called. So is this called as a centrocecal scotoma? Is it a homonymous hemianopia? Is it an arcuate scotoma, or is it a bitemporal hemianopia? So will anyone of you be able to answer this question for me? What is this defect called? So see, what is this defect looking like? What will we call this? So if we draw the field like this, so see, one half of the field here, there is an arched defect which is covering one half of the field, right? So one half of the field, it has been blacked out or it is lost like this. So there is an arch across the horizontal meridian. So on one half of the horizontal meridian, we have an arch like this. This is what is called as arcuate scotoma. And where do we get to see this kind of an arcuate scotoma in perimetry? In which condition do we get to see this kind of an arcuate scotoma? Arcuate scotoma, this is very specific to glaucoma. So when we see this kind of an arch defect that is on the horizontal axis, this is called as an arcuate scotoma, Jerem scotoma, and this is very specific to glaucoma, right? So this is an investigation on perimetry. This is perimetry and one of the important perimetry pictures that we should know for the exam. Now let me show you a few more pictures. These are also perimetry pictures. Now if you look at this perimetry, and we are being told what is identify the site of the lesion. So where is this lesion? Is the lesion in the optic nerve? Is it in the optic chiasma? Is it in the optic tract? Or is it in the occipital cortex? So see, when you look at this perimetry picture, this is the right eye, this is the left eye. Now for each of the eye, this is nasal and this is temporal. So what is this? See, the temporal fields of both the eyes, they have been blacked out, which means that the patient has lost his temporal field of vision. So what is this field defect called? This is called as bitemporal hemianopia. So the temporal field of both the eyes is lost. This is called as bitemporal hemianopia. And what is the site of the lesion? It's obviously the optic chiasma. So at the center of the optic chiasma, the nasal fibers of both the eyes are crossing. So if the center part of the optic chiasma is compressed, then the temporal field of both the eyes goes, and that's called as bitemporal hemianopia. Okay, so these are neurological field defects. So see, these field defects, they are respecting the vertical meridian. They are located on one side of the vertical meridian. Whereas in the previous question, the field defect that I showed you, that was respecting the horizontal meridian. So it was one on one side of the horizontal meridian. So this is a glaucomatous field defect, which respects the horizontal meridian, whereas your neurological field defects, they respect the vertical meridian, as in this case. Okay. Now, taking the opportunity of this question, I will show you a few more field defects. So now look at this. Look at this question. Identify the site of this lesion. So where is the site of lesion for this field defect? Is it the optic nerve? Is it the optic chiasma? Is it the right optic tract, or is it the left optic tract? So what will you say for this? Any idea what we should say? Will you be able to answer this question? What is this field defect? Okay, let me help you. Here also, this is the right eye and this is the left eye. So in this also, see, this is nasal, this is temporal, this is nasal, this is temporal. So here see, the nasal part of the left eye and the temporal part of the right eye are affected. This is unlike the previous picture where the temporal fields of both the eyes were affected. So here the nasal part of the left eye and the temporal part of the right eye are affected. So this is called as a homonymous hemianopia. Right? Now, where do we get a homonymous hemianopia? We get a homonymous hemianopia if there is a lesion in the optic tract. Right? Now, the question is, should we call this as a right homonymous hemianopia, or should we call this as a left homonymous hemianopia? Now, for this, you have to understand that, see, the nasal part of the left eye and the temporal part of your right eye, both of them are on your right hand side. So, look at this picture. This is your right eye, this is the left eye. In a printout, this is right and this is left. Now here you see the nasal part of the left eye and the temporal part of the right eye. Both of them are on the right hand side. So this I will call as right homonymous hemianopia. Now if it is a right homonymous hemianopia, the site of the lesion is the left optic tract. So this is your answer. So here, lot of students, they go wrong because they are unable to, they get confused between right and left. They get confused between right and left, so that's why they go wrong. So please remember that when you get a perimetry printout, first write down the right and the left. And remember, the right and the left are according to your own right hand and left hand. So this is right and this is left. Now in a homonymous hemianopia, see the nasal part of the left eye, the temporal part of the right eye are both on your right hand side. So it's called as a right homonymous hemianopia, and the site of the lesion is the left optic tract. Now why I'm telling you this is, suppose you get a picture like this. Suppose you are going to get a picture like this. This is right and this is left, and you have this part blacked out. If you get something like this, that this part is blackened out like this, then what will we call this? This is then to be called as a left homonymous hemianopia. Because see, the nasal part of the right eye here and the temporal part of the left eye are both on your left hand side. So this will be called as left homonymous hemianopia, and then the site of the lesion is going to be the right optic. And then the site of the lesion is going to be the right optic tract. Okay? Chalo. So this was another question on perimetry. Now let's go to the next question. Now what will you call this? Identify the site of the lesion here. What is the site of the lesion? So is it the optic nerve? Is it the optic chiasma? Is it the temporal lobe or the parietal lobe? What is the site of the lesion here? So see, this is also a homonymous hemianopia, but it's incomplete. So see, this is a superior homonymous hemianopia. the nasal part of the left and the temporal part of the right are affected. So this is a homonymous hemianopia, but it's only superior. So this is called as pie in the sky. Now, pie in the sky is because of lesion where? It is because of lesion in the temporal lobe, or we can say that it is because of lesion in the Mayer's loop. The Mayer's loop, which contains the superior fibers, which contains the fibers of the optic radiation. It contains the fibers of the optic radiation, the inferior fibers of the optic radiation. Right? The inferior fibers of the optic radiation, they pass through the temporal lobe, and that's called as the Mayer's loop. And when you have a lesion there, you end up with this, that is called as the pie in the sky. So this is pie in the sky. Now, the opposite of this is pie on the floor. So if you get a homonymous hemianopia, which is only inferior, if we get a homonymous hemianopia which is like this, which is only inferior, then what will we call this? This is called as pie on the floor. And this is because of lesion where? This is because of lesion in the parietal. So pie in the sky, lesion in the temporal lobe, pie on the floor, lesion in the parietal. Or we can say this is because of lesion in the Baum's loop, which contains the superior fibers of the optic radiation. Right? So the superior fibers of the optic radiation, when they are affected, you get inferior homonymous hemianopia. And similarly, when the inferior fibers of the optic radiation are affected, you get a superior homonymous hemianopia. Okay. Now the last of the perimetry pictures that I have, let's have a look at this. Will you be able to identify this lesion? The site of the lesion, is it the optic nerve, chiasma, tract, or occipital cortex? What will we call this? Yes, see, this is also a homonymous hemianopia because see, the nasal part of the left eye and the temporal part of the right eye are affected. So the nasal part of the left eye and the temporal part of the right eye are affected. So this is a homonymous hemianopia, but the central part is clear here. So this is called as a homonymous hemianopia with macular or central sparing. So this is a homonymous hemianopia with macular or central sparing, and the site of the lesion is the occipital cortex. Now, once again, if we are asked, what is this left occipital cortex or right occipital cortex? So remember, see, this is a right homonymous hemianopia with macular sparing because the blackening is on your right hand side. So the site of the lesion is the left occipital. Okay, so this is a right homonymous hemianopia with central or macular sparing. So the site of the lesion is the left occipital cortex. And which is the artery that is affected if we are asked? This is a PCA territory infarct. This is a PCA territory infarct. Okay, so these are the neurological field defects. So these are the neurological field defects. So the first one that I showed you among the perimetry defects, this is, as I told you, respecting the horizontal meridian. So that's why I am going to call this as a glaucomatous field defect. These are all respecting the vertical meridian. So they are neurological field defects. Okay. So we have bitemporal hemianopia, homonymous hemianopia, pie in the sky, pie on the floor, and homonymous hemianopia with maculus. Okay, let's go to the next investigation now. What is the diagnosis from this picture? So, is this a vitreous hemorrhage? Is it a subluxated lens? Is it a retinal detachment, or is it a posterior vitreous detachment? So, what will we call this? What is the diagnosis from this picture? So, will anybody be able to help me? Correct. This is a retinal detachment. Now, why are we calling this as a retinal detachment? What is this investigation, first of all? This investigation, this is a USG B-scan. This is the ultrasonography B-scan, which is used for evaluation of the posterior segment of the eye when the media is so hazy that you are not able to see the posterior segment even with an indirect ophthalmoscope. So generally, what do we do when we have a hazy media? We use an indirect ophthalmoscope to see the posterior segment. But if the indirect ophthalmoscope is also not able to visualize the posterior segment, then you do a sound-based investigation. That's a B-scan. Now look at this first picture. Now this is a normal B-scan. This is a normal B-scan. Now this part, this black area that you see, this hypoechoic area, this is the vitreous cavity. This is the vitreous cavity. This black thing, this white area that you see, this one, this is the retinochoroidal complex. What is this? This is the retinochoroidal complex. And this black shadow that you see here, this is your optic nerve head. Okay, so these are the structures that you need to identify. So the hypoechoic area is the vitreous cavity. Then the white area that is hyperechoic is the retinochoroidal complex. And then we have the optic nerve shadow. Now in this picture that was given to us, you see this kind of a membranous detachment. And if you look, this is attached to the optic nerve head. See, it is attached to the optic nerve head. So this is a retinal detachment. This is RD. Now, why I am telling you this is, see, you can have a membranous detachment. If it is not attached to the optic nerve head, then we are going to call it as a PVD. That is a posterior vitreous detachment. So, some of you confused it with PVD. See, in a PVD also, you will have a detachment like this, but it will not be attached to the optic nerve head. So, if it is attached to the optic nerve head, then we call it as a retinal detachment. And if this kind of a membranous echo is not attached to the optic nerve head, then we are going to call this as a PVD, that is posterior vitreous. Okay, so this is about our USG B-scan. Okay, now let me show you this question. What is the diagnosis from this picture? So what is this picture? Is it a central serous retinopathy? Is it a cystoid macular edema? Does it show drusense? Or is it showing us the normal picture of the macula? What will we call this? What is this? Is it CSR? Is it cystoid macular edema? Is it drusense? Or is it normal macula? Correct. This is cystoid macular edema. So what is this investigation? This investigation, this is an OCT, that is optical coherence tomography. It is basically a light-based scan of the posterior segment. So this is a light-based scan of the posterior segment. Now this is the normal OCT of the macula. So this is the normal OCT of the macula, and all of you can make out that at the center there is a depression which is the fovea. Right, and you can see the different retinal layers. So these are the different layers of the retina which you can see. This is the vitreous cavity, this black area, this is the vitreous cavity, and you can see the different layers of the retina, and you can also see a depression at the center which is the fovea. Now what do we see in the picture that's been given to us? See, here we see that the macula is thickened, the fovea is elevated. And why it is elevated? Because of the collection of fluid in these kind of spaces. So these cystoid spaces inside the retina where the fluid is collecting is giving rise to this increase in the retinal thickness at the macula, as a result of which the fovea is also got elevated. So this is a picture of cystoid macular edema, that is CME. Okay? So these are the questions that I had in store for you today. So I have gone through some questions on ophthalmic investigations, but there are other questions also which I want to do. So see, we will be having 3 sessions this week for MCQ revision for NEET PG. So today is Monday. So similarly, I will be having a session on Wednesday at 9:30, and again on Friday at 9:30, we will be having a session for MCQ discussions. So I have done a few of the ophthalmic investigations. In the next session, that is on Wednesday at 9 p.m., I will be doing the remaining of the ophthalmic investigations as MCQs, and I will be doing some MCQs on ophthalmic instruments. So that is what we will be doing on Wednesday. Right, so do join me. Thank you for attending this session, and do join me on Wednesday at 9:30 p.m. for the next session of MCQs in ophthalmology for NEET PG. And those of you who are still not a part of our Plus platform, do download the app and become a part of the Plus platform. And for that, you can use my code, that is Dr Sudha. This gives you access to both the live and the recorded classes that are going on the platform, and an opportunity to learn from India's top educators, and also an access to our question bank, which has about 25,000 clinical questions with explanations based on the latest exam patterns. And if you want to become a part of the iconic subscription, which entitles you to both Unacademy and Prep Ladder, then also you can use my code. My code is Dr Sudha. Now, this 26th of February at 9 a.m. we are having this All India NEET PG mock test. Now this, see, a run through before the real exam is always very desirable and also very important. So this test will have questions which will be predictive or very similar to the main exam, and it's an opportunity for you to test yourself in the sense that it's an all India exam, so there will be a lot of students who will be competing for it. And at the same time, if you don't want to compete with others, at least it gives you an insight as to what are the questions that you need to revise, which are the topics where you're forgetting, where you're not conceptually clear, where you have not been able to recall things. So as a test for yourself, I think you should take this exam. So this is on the 26th of February at 9 a.m. Right? And another important news is that very soon we will be coming up for the NEET PG notes, which is comprehensive notes for next. And they have been curated from the live classes of the Unacademy educators, and they will help in effective revision and complement the video lectures of the respective subjects on the platform. And to tell you a little bit about the batches for NEET PG that are running on our platform. So this is a very um, very good opportunity for students who are preparing for this NEET PG May, that is 2022. So this is an all educator revision batch which will be conducting over the next 3 months, and over this 90 days, that is, we will be having 40 plus educators all in this one batch with 140 hours of revision, and we will be covering all the 19 subjects, and there'll also be 8 grand tests. So this is a perfect revision course for those of you who just want to complete your preparation for this NEET PG 2022. And those of you who are in the early stage of your preparation and who are targeting the next 2023, we are having this subject-wise batch, which is going to be a well-structured batch covering comprehensively all the 19 subjects. So these are the two batches that I wanted to talk about for NEET PG 2022 and for next 2023. And for those of you who are focusing on the FMG exam, so we are having this Focus FMG 2022 batch for December FMG, which is going to run for the next 9 months. And there is also, for those of you who want to prepare for the June FMG, we have a batch which is going to run for the next 4 months. In both batches, we will be completely covering all the 19 subjects, followed by revision in the form of MCQs. The only difference is that for the May batch, for the June batch, because we have to complete it in 4 months, we will be doing more number of hours in a day. And the other batch, which is running over 9 months, will be running a little slowly. So these are the courses running on our platform. So those of you who are still not a part of the Plus platform, do enroll for the Plus subscription. And for that, you can make a use of my code, that is Dr Sudha. So thank you everybody for being a part of this session, and the next session of NEET PG MCQ revision, where I will be completing the rest of the questions on investigations and doing the MCQs on ophthalmic instruments. I'll be doing it in the next class, that is on Wednesday at 9:30. Bye bye and good night.